Thank you for joining us today and welcome to this new series of videos from the Practice Protection Committee. I'm Pat Bailey, Medical Director for Advocacy in the DC office, and I'm joined today by my good friend and colleague, Dr. Mark Savarise from the University of Utah, where he serves as an associate professor. Mark's going to be talking to us today about coding and reimbursement and the basics is the first in our series of videos on maximizing reimbursement in the current environment. Mark, thanks very much for being with us.
Thank you, Pat. It's great to be here. I think it's a good idea that we sort of set the stage and the basics as you start getting into the more complicated things that we're going to go into over our next series of talks, so that at least we have a foundation. This is not going into a lot of detail on how coding and reimbursement works. Just talking about our current model of physician reimbursement. The term that's used mostly is fee for service, although you'll hear it called sometimes pejoratively by other names such as pay for volume or eat what you kill. But the whole system is based on a series of CPT codes and relative values that are determined for everything that physicians and other medical professionals do. So these are determined by two panels that are run by the AMA, the CPT panel and the RUC. And then these values are used by Medicare to set their fee schedule for payment. And pretty much every commercial insurer uses this system rather than reinvent their own system. So this is understanding the basics of this system is a foundation for understanding how to maximize your value in it. So let's just talk what a relative value unit or a resource-based relative value unit is. So this is the system that's been in place since 1992, and it started after a study by a bunch of Harvard economics went ahead and assigned relative values to absolutely everything that they could think of in medicine. There are three components to a relative value unit for any procedure, anything from a history and physical to an inpatient visit to a surgical procedure or a radiology procedure. They have the time and effort, which is typically referred to as the work RVU or the RVW. They include some for practice expense, and they include some for liability associated with it. You can see from the pie graph that the vast majority of it is really based on the time and effort involved in each procedure. These values are set by the RUC, the Relative Value Update Committee, and they're reviewed at least every 5 years. For surgical procedures, the relative value unit includes what's called a global period. And every surgical procedure has either a 0-day global, a 10-day global, or a 90-day global. Most of our procedures are considered major procedures. Even outpatient procedures such as inguinal hernia repair are major procedures, and so are classified with a global period of 90 days. So the global period means that all care provided related to that service, from the day before surgery preoperative care to the intraoperative care and the postoperative care, is all included in the value. And from this pie graph, you can see that for most surgical procedures, the intraoperative is the dominant portion of the code.
So Mark, can you give us some examples of some RVUs for some of our more common procedures?
Yeah, sure. Well, here's a table that lists some pretty common surgical procedures as benchmarks, going from laparoscopic cholecystectomy, open, partial colectomy, and Whipple procedure. And what's interesting about this is you can look at the OR time for each of these procedures, the number of visits considered typical for inpatient and outpatient post-op for these, and what that equates to in the RVUs. And you can see that, for instance, open cholecystectomy is worth about 50% more RVUs than laparoscopic cholecystectomy based on the combination of those things. So what determines how much you get paid? Well, the RVU, which is the combination of the work, practice expense, and liability RVUs, are then multiplied by something called a conversion factor. And every year Medicare sets a conversion factor, and then insurers set their own conversion factors by which they multiply the RVU for a procedure to determine your amount of payment. And so you can see here on a table, I've listed the conversion factor, typically $35 to $36 per RVU over the last few years, up through January of 2020.
And that's where this all dovetails into our current efforts in this office relative to the Medicare payment cuts, because that negative 10.61 that you see, that is definitely a sea change and significant negative sea change to what we've seen in the past.
So yeah, Pat, as you noticed, and probably everybody looking has noticed, that number for 2021 is a negative 10.61. Okay, that's a big number. And the reason for the decrease in 2021 is the concept of budget neutrality. And the thing to understand is that physician payment from Medicare is a fixed pie. Every year there is an assigned amount of money, and Medicare uses its conversion factor to adjust for increases in services or increases in reimbursement in certain areas. So for 2021, there's a big change in how things are getting paid. Evaluation and management services are all getting a very large bump, and that means that piece of the pie is getting bigger, and so everybody else is going to be eating a smaller piece of pie going forward.
And that's exactly why we need everyone to continue to be diligent. And even if you've taken action before, we need you to go back to surgeonsvoice.org and click on the Take Action icons and send messages to every one of your senators and your members of the House, your member of the House, to urge them to prevent these cuts that are pending January 1st of 2021 from taking place.
Right, Pat. So the legislation, it would allow Congress to tell CMS, because CMS can't do this on their own, they can't increase the size of the pie. Congress can authorize the pie getting a little bigger so that we don't take it for the increase in the E&M codes in our own surgical codes.
Right. The legislation that the ACS was instrumental in getting introduced by Dr. Barra and Dr. Bouchon does just exactly that. It holds harmless and basically keeps everyone at the same level for 2021 that they were in 2020, because we just really don't think that in the middle of this pandemic is a good time to be cutting people's reimbursement from Medicare.
So that's it. That's your 5-minute summary of physician payment. Your RVUs times a conversion factor equal how much you get paid. It's as simple as that, except it's not as simple as that, right, Pat?
Yeah, Mark, we know that there's a lot more to the story here that you're going to talk about now.
Yeah, so exactly right. There's a whole lot more to it. So as this graph illustrates, payments for physician services are really only 20% of healthcare costs. They're small compared to hospital costs and other costs that go into it. And even though every year we fight for these physician payments, we are not the primary drivers of increases in healthcare costs. So payment to hospitals, which is the largest piece of that pie, is completely different from physician services. We talked about how physician services are based upon your work and your practice expense to a small extent, but the largest part of the expense gets paid to hospitals in a system called DRGs, and that's for inpatients. And then for outpatient hospital procedures, the hospitals get paid on the HCPCS system, but it's substantially different than what we get paid as physicians. And I'll give you an illustration. This is a common surgical procedure, a colectomy. The CPT code 44140 is paid at the current Medicare conversion factor this is for 2020, not 21, $1,400 to the surgeon. If your commercial conversion factor is, say, a typical 65, the surgeon gets about $2,500 or so for it. But compare that with the hospital payments. So for the hospital, they get paid based on 3 DRGs, depending on the number of comorbidities or complications associated with this. And the average hospital cost of colectomy is between $24,000 and $31,000, a difference of about a factor of 10 from what the physician gets paid for this. So the point is, more dollars in healthcare are available than what physicians are getting. And so as we go forward in this series, we're going to talk about how these inequities play into how you get paid and how you are sort of at the bottom of the heap for payment, and how you can climb that heap a little bit by making some practical changes to your practice.
Mark, I know you served previously on the General Surgery Coding and Reimbursement Committee. Tell us a little about your experience with what the ACS does for its fellows in this space?
So this is an incredibly complicated thing. The GSCRC is involved, is made up of a number of volunteer surgeons who put in a tremendous amount of hours. Some of them are members of the CPT and some members of the RUC. We have members on both of those panels, and we have advisors to both of those panels. And then we have our Washington, D.C. staff and several paid consultants who work with us on a regular basis to keep up with the Medicare coding issues, both for coding and reimbursement.
Thanks, Mark, for being with us and providing us this foundational piece for this new series. Our next video will be joined by Dr. Charlie Mabry, and he's going to be talking to us about improving our coding and giving us some tips and tricks in that area. So until then, thanks again for joining us. We look forward to seeing you for this series on maximizing your reimbursement under the current system. Good day.